The next thing is thinking about facilities, and again we've touched on this quite a lot. There is no doubt that the optimal pathway is dedicated day surgery facilities for the entire pathway. I appreciate that that is not possible in every hospital up and down the country unless the government's going to throw out a few millions for us all to develop new day surgery units. But there's also no doubt that as soon as a patient hits an inpatient pathway, it is a lot more difficult to get them through as a day case, because as soon as someone says to them, we don't normally do this as a day case, or there's a bed there for them to get into, or there's a nurse who's not so confident at managing nurse-led discharge for day surgery, or the anaesthetist doesn't really realise that it was a day case and so gives them some morphine and some volatile anaesthetic and they vomit and are drowsy afterwards. Or there's a myriad of reasons why the patient who isn't on a dedicated pathway falls off it. The other thing is we need to protect our day surgery facilities from these blasted inpatients, and you all know what the problems are there. This, I think, is key. A bed or not a bed. There are still units up and down the country who have beds in their day surgery unit. I think that's a disaster for two reasons. The first reason is one of these blasted medical patients will get into a bed. If you have a bed in your day surgery unit, you will come in the morning and there'll be 30 medical patients in it. The other problem is, and some people fall into this danger of, oh, we're going to mix 23-hour stay and day surgery. Again, as soon as you've got beds there, it's easier for the nurse sometimes to put a patient into the bed than to get the patient home. In our day unit, it's really hard for the nurses to find a bed, so they work really hard to get the patients home. So I think, again, if you make the easiest thing to discharge the patient, that's generally what will happen. If you make it easy for a patient to get into a bed, that's what will happen. So think hard. I'm very close to trying to get, in the 20 odd years that our day surgery unit's been open, we've never had a bed or a medical patient in it. We got very close last year for the first time, and then I think they thought about the tantrum I would have and changed their mind. If I was building a day surgery unit again, I would make the doors too small to fit a bed through. And this is obviously the solution. You want trolleys. Ideally, you want operating trolleys. And Neticade, who I have no financial liaisons with, make the trolleys we use, and I have to say I think they're brilliant because the patient hops onto it in the anaesthetic room, has their operation on it, goes through to primary recovery and hops off it to go home. There's no manual handling. It shaves huge amounts of time off the operating list because you're not moving from trolley to theatre table to trolley to this, to that, to the other. I think they're great. So basically, you want your day surgery unit to have no beds. You want them to have no showers and no facilities for cooking meals, delivering meals. Yes, they need tea, toast, digestive biscuits, and no ability to have one of those blasted medical patients in it. But you also want your surgeons to work there. And there is no point asking surgeons to come and work in your day surgery unit and then give them some rusty old screwdriver and a laparoscope that doesn't work and a screen that they can't see on. And traditionally, the day unit was the poor relation. The best kit went to the inpatient theatres and the day unit got what was left. If you want your surgeons to come and do the most complicated surgery and do it well enough to get the patients home, they need the best kit there. And there's absolutely no point making them the poor relations, or that poor staff have to spend 20 minutes every morning phoning up to the main theatre to say, please, please, could we possibly have Mr. So-and-so's foot kit and Mr. So-and-so's nice laparoscopic this. They've got to have what they need down there, and it's got to be properly funded and resourced. Otherwise it won't work. So the argument for dedicated facilities is definitely improved efficiency. And one of my medical students did some work a few years ago looking at our outcomes for hernias through the day unit or through inpatient theatres. And she showed that for the same surgical team, we could do 3 hernias through the inpatient theatres, 4 through the day surgery unit. The surgeon wasn't any faster in one or the other, but the whole turnaround and process was. And as at the time we were getting paid by procedure, that meant 30% more income for the same list if we were doing it through the day surgery unit. If you've got dedicated facilities, the patient follows the day surgery pathway all the way through. You definitely get fewer cancellations because you're not having all these winter pressures and we can't get the patients in and we can't do this and we can't do that. Your day surgery unit will plough through your work day in, day out, whether you're on Black Alert, Opal 3, whatever the latest banding is. Your day surgery patients can still come in. You've got a better chance of getting the patients home if they're through dedicated facilities, and they have better outcomes. Can I evidence that? Yes, I can. This is a few years ago. Our orthopaedic surgeons, bless their cotton socks, decided they knew how to do day surgery and they didn't want to use the day surgery unit, thank you very much. They wanted their day surgery patients to go through some special beds on the orthopaedic ward. I don't know if I've got any orthopaedic colleagues here, but most people would agree that a 16.8% unplanned admission rate through the orthopaedic beds is statistically, clinically and in every other way significantly higher than the 2% for the day surgery unit. So we shut that down pretty damn quick. But then what we did was we didn't have enough capacity in our day unit. We still don't for all our patients. So we opened a satellite day surgery ward as part, it was a bay from an inpatient ward near the inpatient theatres to try and manage our day surgery patients who were going through the inpatient theatres. Even then, we could not get the same outcomes for those patients. And so what we do now is we actually bring all the patients who have their surgery in the inpatient theatres, we then bring them down to the day surgery unit, which is a crap journey for those patients. They have to come down in a lift through an A&E corridor. But when we get them to the day surgery unit, their outcomes are better. This was just to show that not only was the unplanned admission rate lower through the day surgery unit, but also the symptoms afterwards. So the patients who got home did less well if they got home through the satellite unit compared with the day surgery unit. The reason for that is the patients going through the day surgery unit have dedicated nursing staff. The ward is right next to theatre, so if the nurses are concerned, they stick their head in theatre and they say, oh Mary, when you bring the next one out, could you just pop and have a look at Mrs. So-and-so? And I'll pop in and say, oh yes, you need to do this, that and the other. With the satellite unit, the ward's down 2 corridors from theatres, and so if they need help, they can't get an anaesthetist to come out, so they phone the orthopaedic SHO, who comes and says, oh yes, you probably ought to admit them. There just isn't the backup. The nurses are less confident using some of the stronger analgesia because they don't feel we're around to support them, and just the whole process didn't work as well. So what I would say is no day surgery patient should be discharged through an inpatient ward because your chances of getting them discharged are significantly lower. So our ideal scenario, if we're thinking about pathway and facilities, would be complete separation of elective and emergency care, and someone already spoke about that earlier. And ideally, we'd say actually all elective patients are day surgery, and only if they fail to meet the discharge criteria do we admit them. I appreciate there's some caveats to that, and we've already said there are some procedures that would be inappropriate at the moment, but who knows what we'll be doing in a few years' time. Few of us work in that ideal hospital, but we can still do a lot of things to keep our processes separate, to optimise our day surgery outcomes and activity. And to do so not only to facilitate better outcomes for those patients, but if we can get all our day surgery patients and a huge number of other elective patients off the inpatient wards, then actually we can free up those wards for the patients who really need it, for the emergency patients, and hopefully facilitate the flow through the hospital for our medical colleagues.